سليمان كايرو يونيفرسيتي and دكتور ندى حسني جامعة قناة السويس في الإسماعيلية. Case presentation. Each one will be 5 minutes. Okay. ايش هتاخدوا 5 minutes زيادة.
Quite a challenge. So, dear ladies and gentlemen, good afternoon. I have a case today which I chose the title of Runaway Clone. My case is 55 years old female, and she came complaining of anemic manifestations, fever, and left hypochondrial pain. On history taking, the patient reported a previous hematologic disorder. So now, we came to review all her medical records. We found that in 2020, the patient was diagnosed as BCR-ABL positive CML. البيشنت مشيت ازاي؟ She started Glavik on 2020, and her quantitative BCR-ABL was 29%. Then she shifted to Tasigna because her quantitative PCR became 31%. But 2 months later, she developed allergy to Tasigna, and then she shifted to Sprycel. Afterwards, she came back to Tasigna, and her quantitative PCR ABL decreased to 7.4% till it reached 0.01 by 2022. What we call the beginning is often the end. And to make an end is to make a beginning. So the end is where we start from. Let's start my case now. On physical examination, she showed pallor, hepatomegaly, and splenomegaly. Imaging confirmed the hepatomegaly and the splenomegaly 17 centimeter. The CBC showed hemoglobin was 8.5 macrocytic with marked thrombocytopenia, and she was leukopenic. As for the differential count, we found 18% monocytes, and the blasts with blasts equivalents, promonos, and monoblasts were 8%. And this is what we encountered in the peripheral blood. As for the lab workup, the liver functions were normal, the kidney functions were normal, just the ferritin was increased, virology screening normal, and autoimmune profile was normal, ESR and CRP were elevated. As for the bone marrow aspirate, particulated marrow, and we could spot dysplasia in the megakaryocytes, separated nuclear lobes, and hypolobated with monolobated forms. There was erythroid hyperplasia with dyserythropoietic and megaloblastoid changes. We could see some blasts and blasts equivalent. Here we have done the iron stain, and it showed increased stores, but with normal sideroblastic iron, and no ring sideroblasts were seen. By counting, the blasts constituted 10% of the cellularity, promonocytes 4%, and the monocytic element were 8%. So to recap here, we have reported history of CML, organomegaly, peripheral blood pancytopenia with blasts and blasts equivalent 8% and relative monocytosis, tri-lineage dysplasia in the bone marrow with blasts constituting 14% and some monocytic elements. So at this very moment, let's think together what can be the differential diagnosis. First of all, AML with defining genetic abnormalities. MDS increased blasts. What about AML with myelodysplasia related? حد معترض عليها؟ Yes, it was excluded because by definition the blast count has to exceed 20%, and our patient didn't exceed the 20% of the blast count. كان في تفكير تاني لكرونيك مايلومونوسيتك لوكيميا، حد معانا فيه؟ Actually not, because by definition the monocytes did not ما وصلوش للابسولوت كاونت بتاع الديفينيشن بتاع ال CML. فاحنا هنا وقفنا ما بين AML with defining genetic abnormalities and NDS increased blasts. So genes load the gun, but the environment pulls the trigger. Let's have a look on the cytogenetics of this patient. We started by BCR-ABL علشان الهيستوري بتاع ال CML, and it was negative. So here we have a runaway clone. We confirmed our finding with the quantitative PCR, and it was 0.01%. So yes, our clone ran away. هنعمل defining genetic abnormalities of the AML. Translocation 1517 was negative, 1821 was negative, and it was normal for core binding factor beta, and it was negative for 5q, but we found it was positive for 7q deletion. As for the bone marrow biopsy, it was almost normal cellular. Megakaryocytes were a little bit increased, and we could see the dysplastic changes in the megakaryocytes. There was erythroid hyperplasia and increased early forms, increased interstitial immature mononuclear cells. Reticulin stain revealed mild fibrosis with focal accentuation. CD34 by immune histochemistry, honestly, it was heterogeneously distributed with some small aggregates taking the positivity of CD34, but the overall positivity was around 10%, which confirmed our counting in the aspirate. The same as 117, it was positive in around 10%, and it showed increased mast cells. So, our diagnosis was NDS with increased blasts. Simple case, ما كانش فيها حاجات كتير, بس we have a take-home message here. Molecular remission does not always mean disease resolution. إحنا CML الكلون اختفى تماماً وطلع لنا كلون جديد. Persistent dysplasia demands re-evaluation even in treated CML. Beware of the quiet shift actually in any malignancy when a disappearing clone gives way to another. TKI therapy controls CML, but not all clones obey the same rules. Atypical evaluation requires flexible thinking, classification evolve, and so should we. Thank you so much, and special thanks to Dr. Hela, Marwa, and Rihan. خلصت في الوقت.